Yes, sir. Start. 3, 2, 1, start.
So a very good morning. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. So today we have a talk on management strategies in neurogenic lower urinary tract dysfunction. And this would be presented by our resident, Dr. Raghav Khurana, and would be moderated by our faculty, Dr. Dharmendra Jangid. So I would request Dr. Raghav to kindly share his presentation.
Maybe 10 patients for Thursday.
Okay.
Morning, everybody. Today I'll be sharing about the management strategies of neurogenic bladder or lower urinary tract dysfunction. The goals of management are to protect the kidneys, that is the upper tracts. We have to evaluate the underlying disease in order to do so, improve the bladder drainage and continence of the patient, prevention of urinary tract infection and stone disease, and overall improve the quality of life of the patient. Just to summarize what we've discussed in the previous class that included the evaluation, failure to avoid or failure of both functions, we take a very good extensive medical history and physical examination, combine that with the lab diagnosis and ultrasonography of the upper and lower tracts, and along with urodynamic evaluation, which forms the cornerstone of the diagnosis. And then we classify these functions, and further ahead, they are treated accordingly. The storage problems, severe neurological injuries may result in a fixed and open sphincter, leading to an outlet problem. And sphincter damage may also occur secondary to intermittent catheterization and can lead to stress urinary incontinence. Valsalva leak when pressure is the pressure at which leakage occurs during increased intra-abdominal pressure. It is important for considering when we are considering what kind of repair to do with the outlet. Emptying problem related to the bladder. Many patients with neurological injuries, particularly spinal cord injuries, are unable to generate the coordinated impulses and contractions for complete emptying, and they are often dependent on catheterization. Many clinicians advocate medical therapy, and creed voiding may be utilized, although it is contraindicated in patients with detrusor sphincter dyssynergia. Outlet emptying problem is this caused by sphincter dyssynergia. And we have to consider obstruction from anatomical causes such as urethral strictures, BPH, or pelvic organ prolapse. Only after ruling out the anatomical causes do we go into the functional causes. A small new terminology that says neurogenic detrusor overactivity is usually caused in suprapontine lesions. There is loss of inhibition reflex of voiding in the cortex. There bladder sensation is present, but the tone and capacity are normal. The hesitancy is variable. There is no residual urine. Neurogenic detrusor overactivity with sphincter dyssynergia is caused in infrapontine or suprasacral lesions. There is interruption of the descending and autonomic tracts and ascending sensory pathways. It leads to reflex and involuntary micturition. The bladder sensation may be present or absent, and we usually have a small capacity bladder, and residual urine is variable. Detrusor areflexia or underactivity is caused in conus lesions or S2 to S4 lesions in the chorda or nerves. There is interruption of sensory and motor supply leading to loss of reflex and voluntary voiding. The bladder tone and capacity are reduced. The bladder tone is reduced and the capacity is increased to a greater extent. And there is significant residual urine. This is a urodynamic video urodynamics demonstrating a detrusor external sphincter dyssynergia. We can see in the third graph that there is EMG activity as well as PDET is increased. So with the increase in PDET, the EMG activity is present, suggesting that the detrusor is contracting and so is the sphincter, whereas the sphincter should be relaxing at this time. A sample of a bladder diary that is used to track the patient's voiding habits and fluid intake. Now coming over to the treatment part, the treatment can be divided into non-invasive conservative treatment, minimally invasive treatment, and surgical treatment. Non-invasive treatment includes bladder retraining fluid schedule, which is maintained by a bladder diary. There are drugs which I'll be discussing further ahead. Electrical stimulation. We can utilize Creed's maneuver or Valsalva maneuver. Minimally invasive treatment include catheterization, Botox injection into bladder, sphincterotomy, electrical nerve stimulation. Surgical treatments include detrusor myectomy, sacral rhizotomy, sacral neuromodulation, sphincterotomy, bladder diversion, bladder augmentation, or cystectomy with diversion, which may be continent or incontinent. Now coming over to overactive bladder, the first line of therapy is behavioral therapy. Bladder training, bladder control strategies, pelvic floor physical therapy, weight management, and fluid management. Bladder training and bladder control strategies are achieved by maintaining a strict and good bladder diary by the patient. The patient is fully involved in his or her treatment in this scenario. Second line agents are pharmacological management, antimuscarinics, and beta 3 agonists are used. Third line is selective nerve stimulation, which may be tibial or pudendal. We have intravesical Botox injection and sacral modulation. Fourth line is augmentation cystoplasty and urinary diversion. In underactive bladder, we proceed with pharmacotherapy. The agent you most commonly use is bethanechol, but the efficacy is questionable and it has potentially fatal side effects such as myocardial depression. Intravesical electrotherapy is showing promising results, and sacral neuromodulation has also shown to be effective in patients with associated urethral sphincter or pelvic floor disorder. Bladder outlet surgery is performed as a last resort, has high risk for failure of patients not relying on catheter, and patients dependent on catheter have poorer outcomes than those with normal detrusor, but they still do benefit from bladder outlet surgery. Just summarizing what I have discussed and coming over specifically to the drugs, detrusor overactivity is managed by muscarinic antagonists such as darifenacin, solifenacin. Solifenacin is longer acting. Desmopressin can be used as an add-on. Mirabegron beta 3 agonist, it improves bladder compliance and avoids the side effect of constipation as seen with muscarinic antagonists. And botulinum toxin injection into the bladder can also be used. The non-selective muscarinic antagonists that I use are oxybutynin, 2.5 to 5 milligram TDS, tolterodine, 2 milligrams BD, and trospium, 20 milligrams FD. Fusoterodine is a newer drug which has come and can also be used. The M1 blockade causes cognitive decline, and M2 blockade causes QT prolongation and arrhythmias. M3 blockade specifically causes constipation, dry mouth, and blurring of vision. The M3 selective antagonists, which we use more frequently in clinical practice, are darifenacin and solifenacin. They are more cardiovascular safe, but at the same time, they cause more constipation. M3 blockade plus calcium channel blocker is propivarin. It improves bladder compliance in detrusor overactivity. In detrusor underactivity, we usually use a combination of cholinergic agent, bethanechol, and an alpha blocker. Or alpha 2 agonists centrally acting can also be used. They are used mainly in upper motor neuron lesions and detrusor sphincter dyssynergia. Alpha 1 antagonists, which are commonly used, are tamsulosin and alfuzosin. They for all of these alpha they do really result in postural hypotension, may sometimes cause arrhythmias, depression, and dry mouth. GABA A agonist such as diazepam is used in external urinary sphincter spasticity in low motor neuron type of bladder, and GABA B agonist baclofen acts at the spinal level. Opioids can be used. They act on intravesicular nociceptors and inhibit the micturition reflex in select neurological incontinence only. Coming over to a little bit about onabotulinum toxin, it is FDA approved for use in the lower urinary tract. The mechanism is to give 200 units in 30 sites, 1 centimeter apart, sparing the trigone, and it is given submucosal or intradetrusor. It reduces the bladder contractility by inhibiting presynaptic release of acetylcholine from nerve terminals, reducing stimulation of the muscarinic receptors. Its benefits last from up to 6 to 9 months usually, and the most common complication associated is urinary retention, which has been reported in 70% of patients. Less than 1% develop antibody against the toxin, and 1% may develop temporary distal muscle weakness. Electrical stimulation or stimulation of the levator muscles using painless electric shocks and pelvic floor muscles produces a contraction of the levator and external urinary sphincter while inhibiting bladder contraction. This depends on a preserved reflex arc through intact sacral micturition center and can be used in conjunction with biofeedback or pelvic floor exercises. It's used in stress incontinence as well as urge and mixed incontinence, and a stimulation for minimal of 4 weeks is required. Low compliance bladder, the therapy we use is anticholinergic therapy, mirabegron, botulinum toxin, and combination therapy may be used. If all of these fail, then we go ahead with urinary diversion or enterocystoplasty and or indwelling catheters. Retrocessor external sphincter dyssynergia. The first line is pharmacological therapy with alpha blockers, followed by botulinum toxin to the external sphincter. Sphincterotomy with condom catheter or diaper is significant failure and complication rate, but is still one of the most preferred treatments. Intermittent catheterization can also help, but it may cause pain as the sphincter is in a spastic state. Sphincterotomy is the standard of treatment. The level of evidence is 2 in recommendation A, and the outlet resistance can be used without completely losing the closure function of the urethra, and the laser technique is more advantageous. In increased outlet resistance due to smooth muscle sphincter, we may go ahead with bladder neck incision or a YV plasty at the level of striated muscle sphincter or sphincterotomy, which may be surgical or pharmacological. Pharmacological using alpha blockers or Botox injection. Urethral stents may be used. Pudendal nerve interruption has also been shown to benefit, and urinary diversion. This is a picture showing the bladder neck incision at 5 and 7 o'clock, extending from the ureteric orifice up to the bladder neck. Poor outlet resistance may be seen in sphincter insufficiency. Here we have a few options such as bladder neck reconstruction, occlusive slings, artificial urethral sphincter, or use of a condom catheter. Sacral neuromodulation is experimental, has been studied in mixed populations. The short-term results are promising and is used in lower urinary tract symptoms and dysfunction of bladder storage secondary to neuromuscular causes. The expanding indications of this sacral neuromodulation include neurogenic bladder, interstitial cystitis, pelvic pain, pediatric voiding dysfunction, and bowel disorders. It is usually done in 2 stages. The first is the temporary or permanent lead for external stimulation. And stage 2, we implant a pulse generator that is a permanent implantation. A small video depicting the insertion of sacral neuromodulator. So this is the, surface marking showing where to insert the needle. So it is the S3 foramen is at the 2 centimeters lateral, bilaterally, at the level of the inferior border of sacroiliac joint. Bilateral needles are inserted, and following which we will insert an electrical lead after inserting the sheath. This is a lead that with electrodes that is inserted and will go directly to the S3 foramen. This is inserted under fluoroscopic guidance, following which the electrode position is checked and using the plantar reflex. The device commonly uses interstim, and then we tunnel the lead as it is a little long and has to be implanted somewhere. So we tunnel it across, and then we add the battery to the lead. So this is the interstim device by Medtronic. This is then connected we connect the lead to the battery, and then the battery is implanted and kept there. Checking it under fluoroscopy, and we have finally inserted the neuromodulator device. Now coming over to catheterization, it is of 3 types. We use indwelling urethral catheters, suprapubic catheters, or intermittent catheterization. It's usually used for atonic bladder with overflow incontinence or overactive bladder with detrusor sphincter dyssynergia. Intermittent catheterization is the standard treatment for patients who are unable to empty their bladder. Patients should be well instructed in the technique and risks. Aseptic intermittent catheterization is the method of choice. The catheter size should be 12 to 14 French. Frequency is 4 to 6 times a day, and bladder volume should remain below 400 ml. Indwelling transurethral and suprapubic catheterization should be used only exceptionally under close control, and catheters should be changed frequently. Silicone catheters are preferred and should be changed every 2 to 4 weeks, while coated need to be changed every 1 to 2 weeks. IC is associated with fewer long-term complications, including upper tract changes in comparison to chronic indwelling catheterization, and should catheterize at volumes that are safe by urodynamics. We can catheterize more frequently to prevent incontinence also. Suprapubic tube, the complications associated are chronic bacteriuria. We have to monitor for stones. The tube may not drain well if the gravity or due to gravity or kinking. There may be loss of capacity or compliance of the bladder. There may be incrustation on the tube, and we need to change it more frequently. An artificial urinary sphincter is also helpful in these cases. The cuff is inserted into the urethra. The control pump is usually inserted in the scrotum, and the reservoir in the suprapubic area. Urological reconstruction, it is the permanent option for end-stage disease. The UDS evaluation to assess storage and emptying parameters is crucial to determine the options for patients requiring reconstruction. The indications for reconstruction are persistent incontinence, loss of compliance, and upper tract deterioration, recurrent urosepsis, patient preference, or difficulty with intermittent catheterization. Reconstruction is dependent on the disease type and possibility of progression, manual dexterity of the patient, reliability, desire for continence, socially acceptable management. There is no one-size-fits-all reconstruction that is applicable to all patients. The reconstruction may be a continent such as Indiana pouch or cock pouch, or a catheterizable stoma, Mitrofanoff or Yang-Monty, or incontinent like ileal or colonic diversions. In tetraplegic patients, we prefer ileal conduit plus minus closure of the bladder neck, and urethral obstruction risk is less. The residual urine within the bladder, there is long hospitalization, which may lead to ileus, and concurrent colostomy or is a questionable thing that we might have to do. Types of reconstruction are augmentation cystoplasty, reduction cystoplasty, bladder neck reconstruction, diversion with concurrent cystectomy, which may be continent or incontinent. Bladder outlet reconstruction is one method of restoring sphincter continence in patients with a fixed and open bladder outlet. It was introduced for treatment of urinary incontinence, but has been modified by Dees, Ledbetter, and Tanago. And it is now also used for bladder outlet reconstruction is now used in patients where the outlet sphincter is damaged, or there has occurred a neurological injury causing the sphincter to be non-functional. The long-term success rates have been reported to be between 60 to 70%, but it is difficult as this is not a frequently performed procedure. The striated muscle is wrapped around the neourethra, creating a neobladder neck, and suspension sutures are tied over the rectus fascia, creating a neo-sphincter sort of a thing, which happens, which improves the function of the external sphincter. Augmentation cystoplasty is most commonly performed with ileum or colon. Auto-augmentation may also be utilized, and augmentation with ureter has been utilized, but it is not as reliable for volume. Myoplasty using latissimus dorsi or transversus abdominis muscle has been also utilized. Selection is dependent on the surgeon preference and anatomy and length of the intestinal segment that is to be used. A concurrent catheterization channel may also be used. Detubularization and wide cystostomy is the first procedure that we do. This is a star-shaped cystotomy that has been created, and detubularization of the ileum, and following which the bladder has been augmented. This is a continent cystoplasty. Now, complications of bladder augmentation are risk of rupture. Complications of bladder augmentation include risk of rupture, hyperchloremic metabolic acidosis. There may be weakness, fatigue, or thirst. Progression of renal failure may occur, causing osteomalacia, demineralization. Vitamin B12 and folate deficiency may also happen, and the treatment is by bicarbonate replacement. This is a picture demonstrating a furtry appearance of the bladder and a VUR in neurogenic bladder. A Mitrofanov procedure can also be used, wherein a tuberized intestinal segment is used and which may be catheterized either permanently or intermittently. A Yang-Monty procedure has also been shown to be beneficial in cystoplasty. The need for additional surgery after augmentation, we may require surgery for bladder stones. A second augmentation may be required. There may occur a bladder perforation, bowel obstruction, or recurrent UTI sepsis. Upper tract monitoring after management of a neurological bladder is usually indicated typically yearly. The most common modality is renal ultrasound. If there is high suspicion for stones, additional pathology, we have to consider CT imaging. Functional assessment is usually done with laboratory investigations in the serum creatinine and calculated GFR. Renal scans are may be indicated in a few select patients. Once a hydronephrosis is present, there already is a renal damage that has set in. Patient factors to consider when choosing therapy. We have to consider the prognosis of the underlying disease, especially if progressive or malignant, the general health of the patient, limiting factors pertaining particularly to a single patient, such as inability to perform certain tasks, and dexterity, ability to transfer or body habitus, as occurs in paraplegic or hemiplegic patients. Mental status of the patient, motivation of the patient and compliance with treatments, desire to remain catheter or appliance free, and desire to avoid surgery. The sexual activity status of the patient is to be considered. Reliability and educability of the patient is also to be considered, and psychosocial environment interest and cooperation of the family members is very important. Economic resources in a country like India, where we have limited resources, a lot of newer therapies are not immediately available to all the patients, so we have to consider everything while managing a patient. The reasons to change or augment a given regimen include the upper tract deterioration, recurrent sepsis or fever or of urinary tract origin, lower tract deterioration, there is inadequate storage or inadequate emptying, inadequate control, and unacceptable treatment side effects. That's all for right now. Yes.
Thank you, Raghav. Yes. So I would just like to know if Dr. Mayank has joined us or anybody which we have invited as an expert. Mr. Nimesh, just let me know if anybody else has joined, right?
Okay,
as, as expert, right? So thank you. So neurogenic bladder, as I said previously also, that the newer term is neurogenic lower urinary tract dysfunction. So we should change the term. And it's a very important subject in the sense that many of these patients of neurogenic lower urinary tract dysfunction would be diagnosed quite late. And when they are diagnosed, they have back pressure changes, upper tract deterioration, there is chronic kidney disease, and they suffer a lot, not only medically, but also the quality of life is very poor in these patients. So we should be on lookout for these patients, how to improve their functionality, how to improve their management, how to decrease the progression of the disease in these patients. So before we go into evaluation, we must know what are the various causes of neurogenic lower unit tract dysfunction. It could be congenital, acquired. There are various congenital causes, as you know. So all these causes would actually either disrupt the central nervous system or the spinal cord or the peripheral nerves. Central nervous system congenital causes could be hydrocephalus, cerebral palsy, and spinal cord lesion like spina bifida, which could be cystica or occulta. Cystica in the form of meningomyelin. Acquired causes could be a lot many. They could be infective causes like transverse myelitis, Guillain-Barré, and other infective pathologies. They could be traumatic like brain injury, the spinal injury. They could be tumors like brain tumors, spinal tumors. So all these causes should be kept in mind. Besides, there could be some patients which do not give any history of any neurological problem, but they actually have the neurogenic lower unit tract dysfunction once you start evaluating. So in evaluation, important the history part. You try to find out the various causes which could have resulted in this problem. Then you also try to find out the patient's functionality, like whether his cognitive function, the hand functionality, the dexterity, the quality of life. All these are very important while managing these patients. So while investigating these patients, important, do always a urine routine examination or a dipstick test. If the patient has infection, do a urine culture. Get a baseline renal function test. And you need to do some kind of imaging to know the upper tracts. The gold standard being the video urodynamics, which will tell you the various functions of the bladder, urethra, the sphincter, and whether there is any incoordination between the central nervous system and the spinal cord or bladder and the sphincter. So while talking about the management, as he said, important is the behavioral therapy. In the behavioral therapy, it's important to have educate the patient, which is very important. Secondly, regarding the timed voiding, the bladder training, the physiotherapy, the Kegel exercises, all these are very important part of management, including the fluid management, the restriction at night, and dietary management. All these are important. While taking the history, again, important in neurological patients would be to take a proper history of the bowel function and the sexual function, which is very important, and the lower limb deficits and or any muscular pathology. So all these could be associated in these patients. So you need to have a proper physical examination, which not only includes the abdominal genitalia and the rectal examination and female's vaginal examination, but also a focused neurological examination, which will include not only the sacral reflexes, the perineal sensation and the sensation in the perineum, but also the lower limb reflexes and sensations, which will tell you exactly where the lesion is. In most of the patients, the lesion would be a mixed kind. We know the various classifications of neurogenic lower unit tract dysfunction. The most simplest would be the urodynamic classification, which will tell you about the bladder function, the urethral function, the sphincter function, whether it is hypoactive or hyperactive or normal. The Lapidus classification is again also very good, which will tell you about whether this is a motor paralytic bladder, is a sensory neurogenic bladder, it's a reflexive bladder, reflex bladder, autonomous bladder, or an uninhibited bladder. While taking the history, it is important to find out 3-4 more pathologies. Detrusor sphincter dyssynergia is very important, cauda equina syndrome, and if the patient has autonomic dysreflexia, because these things require special management. While talking about urodynamics, it's very important to know the detrusor leak point pressure or the sustained intravesical pressure. If it's more than 40 centimeters of water, then the chance of upper tract deterioration. So the management should be in a very aggressive manner to prevent deterioration of the upper tract. Then we talked about the behavioral therapy, then pharmacotherapy. He talked about the antimuscarinics, the alpha blockers, sometimes the desmopressin. We quite often use bethanechol. So these are the various pharmacotherapy medications. And then we have Botox. Botox injection, as you said, it could be given both intradetrusor or submucosal, plus it could be given to the sphincter if there is a detrusor sphincter dyssynergy. And the side effect of Botox, as you said, is around 70% retention, which probably is not true. I don't know where you got this data from, but usually the various studies tell you that it may vary from 5 to 35% or 40%. So one of the latest studies showed there is a call, the retention was around 30 to 35% if they have not properly chosen the patient. So usually you would not give Botox if the post-void residual urine is more than 100. So if you exclude them, then the causes of the chance of retention would diminish even further. Then we have the neuromodulation, the sacral neuromodulation. You said about that it is experimental. It's no more experimental. The FDA has approved it, and it is part of the clinical management of neurogenic lower urinary tract dysfunction. So all these, when do not work, then neuromodulation is another management which has definitely benefited many patients. It's not only for detrusor hyperactivity or overactive bladder, but also patients who are in retention urine or detrusor hypoactive detrusor. Then the last thing would be, and the PTNS, percutaneous tibial nerve stimulation, is also one of the treatment. And the last would be the surgical management. So surgical management would include the various augmentation cystoplasty, reduction cystoplasty, then sphincterotomy, then sacral rhizotomy. So all these are various surgical procedures which may help in neurogenic lower urinary tract dysfunction. One thing about the many patients who have a hypoactive bladder areflexias, many females would come with a very stretched out bladder with a large capacity bladder, very thin detrusor. So one of the thing that you said is a myoplasty or sometimes a reduction cystoplasty you do if there is a large capacity bladder. In one of these cases, I remember we did detrusorrhaphy. Detrusor, when the bladder is very thin now and very large capacity, then in these patients, you can just plicate the detrusor muscle, do a detrusorrhaphy to reduce the capacity plus increase the detrusor wall thickness. So that may help in some of these patients who are have a poor detrusor contraction. So in that patient particularly, it worked. So I remember that case where we did a detrusorrhaphy in one of the patients. I think we also must remember the complications of neurogenic lower urinary tract dysfunction and how to follow up these patients, which Raghav has already done. So I think that was all. If any of the residents or faculty has any question, or those who have joined us today have any question, please raise your hand. Otherwise, we will go to the MCQs. So residents, do you have any question? Faculty, would you like to have any comments? Anybody from Dr. Mayank, have you joined? I think he hasn't joined. Anyway, so any of the people who have joined us from outside, if they want to say anything, please, they are welcome. And now we will go to the MCQs. So the first question is, in the medical management of neurogenic detrusor overactivity, which of the following is least likely to worsen constipation? Oxybutynin, mirabegron, tolterodine, tamsulosin, trospium. So tamsulosin is not used for overactivity. So tolterodine, trospium, oxybutynin, all these are muscarinic, anti-muscarinics, and most of all they cause. Mirabegron is a beta-3 agonist, which doesn't cause much of constipation, right? When we talk about anti-muscarinic, you must know which are the anti-muscarinics which can be given in the old age, right? So trospium hydrochloride, which doesn't cross the blood-brain barrier, is a very good medication in when you have a poor cognitive function or dementia in patients of old age. Secondly, derifenacin is a better drug because it has less cardiac issues and is better tolerated in older age. So mirabegron is the answer. A 65-year-old man who has sustained a stroke but is otherwise in good health has symptoms of hesitancy, straining to avoid urgency and frequency. The optimal next step management is anticholinergic therapy, transurethral resection of the prostate, transurethral incision of the bladder neck, CIC, a full urodynamic evaluation. All right. A 65-year-old patient may have a problem related to prostate, but again, he needs a proper evaluation because he has a stroke also, which can result in overactive bladder. So we need to evaluate this patient. It's not just a urodynamic evaluation. He has to be evaluated properly for with proper physical examination for his enlarged prostate, for PSA, everything, because the same symptoms could be due to enlarged prostate also. So many people, many of these are they can coexist, right? Stroke and this. So it's not necessarily this, all these symptoms are due to stroke only. Particularly, the obstructive voiding symptoms would not actually be due to stroke. So a full urodynamic evaluation is required in these patients. What is the optimal management of a 65-year-old man who has had a first occurrence of urinary retention after radical pelvic surgery? Anticholinergic therapy, clean intermittent catheterization, TURP, external sphincterotomy, methanol chloride. CIC. So first occurrence of urinary retention. So if he is developed, you first put a catheter. Yes, so he needs a catheterization definitely. But if he wants to have, if he needs a long-term catheterization, then definitely he has to be switched to clean intermittent catheterization. Many of these patients were after the radical pelvic surgery, because of the damage to the nerves, peripheral nerves, they will have a problem, which could be both motor or sensory, right? So again, you should, in the history, you should know the various causes of sensory neurogenic bladder. The sensory neurogenic bladder could be due to diabetes, tabes dorsalis, pernicious anemia. It's very important. And the motor causes could be due to, like if you if you ask about the infections, herpes zoster is a very important cause for motor paralytic bladder. Besides the other neurological causes, peripheral nerve injuries, the damage to the nerves, etc. So again, what is the answer here? CIC. Is that right? Right. Which of the following statements regarding parasympathomimetic agents in detrusor underactivity is true? Muscarinic agonists show good efficacy in restoring contractility. Muscarinic agonists are more likely to be effective in patients with complete bladder denervation. Muscarinic agonists can cause severe cardiac depression. Anticholinergics can cause uterine contraction. None of them. So a large dose can cause cardiac depression, right? So that is one of the side effects. But clinically and practically speaking, we have been giving bethanechol almost in many patients. Even 50 milligram TDS have been given, and practically we do not find any of this side effect. But it needs a kind of a study, I think. In India, a lot of urologists are using bethanechol, and I think it would be very appropriate if we can do a study on bethanechol hydrochloride. And many of these patients do benefit. It's not that it's just empirical or just anecdotal, but many of the patients do benefit. So we, I think, must do a good study on bethanechol. What is the proposed mechanism of action of intravesical electrotherapy? So you didn't discuss about the electrotherapy. You just mentioned about electrotherapy, direct stimulation of detrusor myocytes, stimulation of mechanoreceptive afferent nerves, direct stimulation of efferent nerves, inhibition of pathologic urethral efferent signaling, stimulation of mechanoreceptive afferent nerves. So this helps in it helps to improve the detrusor contractility. Again, I think this is experimental. This hasn't come into clinical practice. We need to know a little more about electrotherapy because there are a lot of patients who suffer from hypoactive bladder, and we do not have any pharmacological treatment for these patients. Which of the following is the first-line management of patients with detrusor overactivity? Antimuscarinic, behavioral modification, intravesical, Botox, augmentation system. So, antimuscarinic, right? Or either you want to say the behavioral modification. Behavioral. So always you should start with behavioral modification. But if the symptoms are quite significant, then just simple behavioral would not help. So always you may add behavioral with pharmacotherapy. So it depends upon the type of the patient that you are. So if it's a mild symptoms, you can just give behavioral therapy. Otherwise, a combination of behavioral and pharmacotherapy. All right. So all these behavioral therapies do help in many of these patients: timed voiding, bladder training, physiotherapy, Kegel exercises, weight reduction, diet management, fluid management. So all these are very. Which of the following the best treatment options for patients with detrusor sphincter dyssynergia? Pharmacological therapy with alpha blockers, there's a Botox, to external sphincter, sphincterotomy, intermittent catheterization. All right. What do you think? So alpha blockers doesn't help, right? For dyssynergy. Botox is one of the treatment. Sphincterotomy is the next priority. And intermittent catheterization would not help in these patients. Right? So what do you think? Botox? So the best treatment, again, the sphincterotomy is a very kind of a operation which has no that's a thing which is the last thing to do because it's an irreversible thing. Once you totally damage the sphincter, it will not ever come. So the patients who are not helped by anything, the last option would be sphincterotomy, I think, and that could be the very good option, but should not be the first line management in such patients. Botox could be tried. If Botox is helping in these patients, then probably for the long-term therapy, you can do a sphincterotomy. So sphincterotomy is probably the best way to do it. But again, you must be very careful before doing sphincterotomy. The patient will be totally incontinent, right? So he will be on condom catheter completely throughout. So you have to counsel the patients properly. You have to know exactly what they require before doing a sphincterotomy. I think that was the last question. Thank you very much. Any of you, again, have any query or any question? Please let me know. Any of those who have joined us, a lot of people joined us. So if any of you have any question, please let me know. Otherwise, we will ask Dr. Dharmendra, our moderator. Yes, please go ahead. Come here. The question, this is all going online, so we cannot just talk in between between ourselves. So the question from Dr. Jaiswal was, a child 5-year-old with spina bifida is holding 100 ml of urine, and what should be the treatment? So our resident would just.
So we have to manage. We have to look for infection and manage the outlet first, and we have to insert a catheter and protect the upper tract first. Following which we go in for a complete evaluation, and then spina bifida. There has been shown that detethering of the cord and these things have helped in the management?
That was for meningomyelin. That was probably when he was born, he was operated for meningomyelin, but many of these patients may have tethered cord later, right? So definitely these patients require follow-up, and we need to do, if necessary, MRI also to know exactly what is if there is any residual pathology, if there is any tethered cord problem. So all these needs to be evaluated in such patients, and then you have to deal the actual dysfunction. What is the actual dysfunction? Usually with spina bifida, most of these patients may have a kind of a retention of urine or voiding difficulty. So they would require a kind of a combination of antimuscarinic and a clean intermittent catheterization. Most of these patients, because if they are not voiding properly, then the bladder needs to be relaxed by giving antimuscarinics. In children, the best way to do is oxybutynin, and then clean intermittent catheterization if the patient is not able to void properly. So. So most of these patients, if they are not actually voiding, so it's a total retention of urine, then definitely we have to, usually they will not go into retention of urine, and they may require some, if there's a slight increased residual urine, you may give a slight dose of alpha blocker to help the bladder neck relax, or sometimes. But if there is retention, definitely he would require either catheterization, or if the catheterization has to be prolonged, you can put a suprapubic tube also. We have to know the upper tract deterioration in these patients. So how deteriorated is the upper tract? If there's a large bilateral grossly hydronephrotic kidneys, or whether there's a bilateral vesicoureteral reflux, so all these would tell us how to deal with such patients. So many of these patients who are in CKD, the grossly hydronephrotic kidneys, they may need diversions. So percutaneous nephrostomy can be done in such patients, because the peristalsis is also very poor of the ureter in such patients. So we have to personalize our therapy in the form of the particular index patient which we are dealing. Yes, so that's how you do it. You do in a stepwise manner. Stepwise manner. Mitrophenol would be the last option for patients who have the bladder dysfunction. Is not able to do, then yes, if you think he's not able to void at all, he's requiring a long-term kind of a treatment, then definitely a surgical option is there, and you can do a continent pouch in the form of mitrophenol, or even the young Montes with the ileal kind of a segment. So yes, that would be the last option. Anybody else? Yes, go ahead. Yes, so this has already been dealt many times, that patients who are asymptomatic bacteriuria patients, even those patients who are on catheter for long term or on clean intermittent catheterization, do not require antibiotics. Unless the patient is symptomatic, there is a chance of recurrent urinary tract infection. The patient has gone into urosepsis, then you require treatment in the form of antibiotics. All patients of neurogenic lower urinary tract dysfunction, whether they are on catheter or intermittent catheterization, do not require antibiotic, even if they have bacteria. Right? Anybody? Okay. So thank you once again, Dr. Dharmendra. Okay, so I thank the moderator, I thank the presenter, Dr. Raghav, and all my faculty and residents, and all those who have joined us today in our class. Thank you very much, and have a good day.